Thank you, Dr. Nayak. Now we'll have Dr. Ashok Sharma, who is going to talk to us on principles of stethoscope and its application, endothelial photography and placidodisc photography.
Good morning, everybody. At the outset, I would like to thank Dr. Beaton for giving me this opportunity. My topic is principle of sham flood and its application, endothelial photography and placidodisc photography. I would start in the reverse order because that will give me opportunity to have some continuity and some benefit of excellent talk by Dr. Nayak. I don't have any financial interest in this presentation. Spectral microscopy as like the endothelial cell photography is based on simple principle of specular reflection. And in specular reflection, basically, it's very simple that the angle of the incidence and the angle of the reflection is equal once the light is reflected from a regular surface. The same thing does not happen if the surface is irregular. When we take the cornea, we have two surfaces, cornea, epithelium and endothelium. Right at the moment I will be concentrating on the endothelium only. We have endothelium and aqueous layer interface where the refractive index is different in two. When we have the incident light, most of the light goes refracted into the eye, and only because the refractive index difference is very little, so only 0.02% of the light is specularly reflected if the surface is regular. If we have some irregularity on the surface because of corneal gutata or some pigment distribution or something, then we get diffuse reflection. This is what we get. We have the light falling on the cornea. This one falls on the epithelium and we get the reflex from the epithelium. This one falls on the endothelium and we get the endothelial mosaic, which was explained in the previous talk. Surprisingly, as we discussed, the light reflectance is very little, so it's very difficult to photograph them. Or the other thing is that the light specularly reflected from the epithelium is also very close, and some light disturbance from the stroma that makes the picture very difficult. But as explained by Dr. Nayak, we can always see the endothelial cells, and believe me, when we were not having specular microscope so common, I used to demonstrate my residents specular reflection and the examination of endothelial mosaic on the specular reflection only with the slit lamp only. The technique has been beautifully explained earlier, but I would just like to emphasize that in the beginning, what you can do is you can take keratoconus patient. Keratoconus patients had thinner cornea and you will see better reflection. And this article is in Ophthalmic Surgery and Lasers in 1984. You can read that and you can refine your technique. One thing is there that once you go close to that light reflex, just by the side of the light reflex, you narrow down your beam and then have the highest magnification. And I would advise you to use one eye only, because if you use one eye, you will see the endothelial mosaic more clearly. The same thing, once we capture it with the specular microscopes, we can see it. The first specular microscope was designed by Morris, and subsequently we have much more sophisticated instruments which provides us a magnification as well as software for various calculations and statistical analysis. Widely speaking, it's basically two types, contact and non-contact. In contact, we have to apply it at the surface and put topical anesthesia. But the advantage of the contact microscopes is that it gives you wider field for examination, and you can examine more number of cells. Whereas the non-contact, because of the corneal curvature is not flattened, so the field is limited. You will have less number of cells. But for the matter of convenience, it's only the non-contact which are preferred. You can use various software methods to calculate the endothelial cells depending on which machine we are using. We have various methods. You can use corner methods. You can outline these cells, or you can have the center method where center to center cells are calculated. The main parameters which we rely, they are cell area, cell density, polymorphism, pleomorphism. Pleomorphism is basically the percentage of the six-sided cells. If we talk of the perfect corneal endothelium, probably 100% of the cells should be six-sided, hexagonal, because that gives the maximum number of cells being fitted into the frame. But it's up to 60% of the cells, if they are there, we say the cornea endothelium is normal. This is how the cell density and the coefficient of variation is calculated. This gives you the idea that how many number of cells are there. At birth, we have something like 3,000 to 4,000 cells per millimeter square, which decreases because at birth the corneal diameter, after birth the corneal diameter increases, and that is the reason the cell count goes down. In the middle age, we have something like 2,500 and subsequently 2,000. People say that up to 800 cells per millimeter square is basically potential for edema, but we have seen cornea surviving even below that. This is just the polymagatism. You can see the CV basically, and if the CV increases, you can see the polymagatism becomes evident. This is just to show the basics, how the abnormalities they occur. If you have a like something like iris, the pigment over the back of the cornea, and the light, more light, or if you have a very regular abnormality, sometimes more light is reflected and you get a light area in the specular mosaic. But if you have some abnormality like corneal gutata where the specular reflection does not occur, you will have a dark area. And this is how the dark areas they look like on specular microscopy. And this is evident of Fuchs endothelial dystrophy. This is one of our patients where we are following him on specular microscopy, and is still the endothelial cells and the gutata, they are constant. We can diagnose posterior polymorphous dystrophy. This shows vesicular changes, endothelial lesions, and irregular toxicities. IEC syndrome, it has epithelial-like cells which have like various shapes and they have proliferative capacity. This is what I was talking. We have a corneal graph which was done about 6 years back, and I suddenly decided to do specular microscopy to see it, and the surprisingly cell count was 410. I was frightened, but 4 years down the line, still the graft is very clear. The other patient, he had developed cataract, had a very low cell count, but we have done cataract surgery in corneal transplant patients with around 600, 700 endothelial cells. This one has 578, and still the graft remained clear for like variable period of time. But still they are clear. And I still say that if the low endothelial cell count is there, cataract is there, you can still do the corneal transplant. Coming to the next part of the presentation, that is the Placido-based systems, and this is based on the reflection system. We know that the anterior surface of cornea is just like a convex mirror, and once we reflect the multiple, the Placido-based system, multiple rings we get on the cornea, and the reflected image is captured on a charge-coupled device in the camera, and then the computer software analysis. The optical principle is very simple. We have an object here, and then this is the zone of reflection. This is the image of the object. It is the zone of the reflection which we are concerned with in topography. The larger the size of the object, larger is the zone of reflection, and if the distance between the object and the zone of reflection is less, again the size becomes more. If we have the larger size of the zone of reflection, we get more information about the cornea, maybe from limbus to limbus. Once we see the corneal topography, we should look at basically the colors. We all know that the warmer colors, red, orange, and yellow, they represent the steeper part of the cornea, whereas the cooler colors, green, blue, they represent the flatter part of the cornea. Once we look at the colors, we should not forget to look at the scale which has been used, because abnormalities, that depends upon which type of the scale has been used. If it is the absolute scale, it uses the preset color scale. And the same dioptric steps for that range, and the steps can be in the increment of 0.5 diopter or 1 diopter. So look at that, what is the increment. Whereas in the normalized scale, the steps are basically the smaller. So once the range is small, then the more information is obtained on the spectral microscopy. We have some of the statistical analysis also done on this, and we can have all this information about the astigmatism, irregularity of the cornea, depending upon which gun we are using. This gives about the shape of the cornea. Q value, basically, this one should have been more than 0, and if it is less than 0, that means the cornea is prolate, which normally it is, and if it is less than 0.26, the cornea is more steeper and it's keratoconus. Axial and tangential displays, they are being looked into the corneal topography more often, but we know that it's basically the tangential which gives more accurate information. On axial, you can see the bone is coming up to the limbus, whereas on tangential it is going local. Some of these normal topographic patterns we should be aware of when we are evaluating, like we have round, we have oval patterns. We can have symmetric bow tie, we can have asymmetric bow tie, we can have irregular corneal pattern. Diagnosis of keratoconus cornea, advanced keratoconus is evident. We have the clouding of the Mayas in the area where the steepening is there, and we can have the inferior steepening, and again the more evident curvature, increased curvature. And pellucid marginal degeneration, we can have lobster claw pattern of the corneal topography. The vertical meridian is flattened. We have flat bow tie and sometimes asymmetric bow tie. One of the limb of the flat bow tie is missing. We should also remember that we can have artifacts in the corneal topography. This picture shows that there is a perfect centration, and we have with the rule astigmatism, whereas if there is some misalignment, the same patient, it gives the inferior steepening, which is false inferior steepening. The placido-based systems the outcome is also affected by the tear film abnormalities. In this one, we have the inferior pooling of the tears and there is an inferior steepening. Whereas if there is a drying of the cornea because of some reason, we can have the flattened appearance in the same. Once we are using placido-based system, we should be aware that the central corneal curvature is not measured. It is basically an estimation. And there is no evaluation of the posterior corneal surface on placido-based systems, and also the corneal thickness measurement is not possible, it's not available to us. So once we are using this as a screening tool for refractive surgery, we should always remember that we will have to use corneal thickness from ultrasonic measurement, but that too may not give us the minimum thickness because we may miss the thinnest point. We have another area, sham plug principle, which will have some of which will take care of some of these disadvantages. This principle was given by Theodor Scham-Plug. He's an Austrian who invented the device to give us accurate photographs over a wide range. Basically, we can see that if the object is obliquely placed, the photograph may not be perfect. Professor Hopwin used this principle to give us imaging of the anterior segment. You can see some of the photographs. If you have just the frontal plane, it's fully focused, but if you have the oblique, it will not be fully focused. So that this problem is taken care of once you use the Scham-Plug principle. The principle is that the objective plane, the film plane, and the focus plane, they should all intersect at one point. And in Pentacam, this principle has been used by using two cameras. One camera controls the fixation, and the second one is mounted on a rotating wheel. And this camera rotates from 0 to 180 degree, and this takes care of the problem of the no shadow. This is very fast camera. It takes the 50 slit images in 2 seconds and measures 500 points on each slit image, uses 2500 elevation points, and then generates a 3D image. This is the sagittal system in which at a particular point a tangent is done and then normal to it where it meets the reference line, that is the radius of curvature. So we know that this is in this one the power is calculated by using a formula, whereas in tangential method we use the circles and the radius of the circle gives us the accurate information. Once we compare the two, the tangential map basically depends upon the local circles, and this gives more information and reveals more corneal irregularity basically, and these points are independent of each other. Although this gives us more information, but basically we are used to, it's basically the sagittal map which is widely used. On the Scham-Plug image on Pentacam, we can always have the anterior surface elevation and the posterior surface elevation, which is very important when we are diagnosing the keratoconus or ruling out ectasia risk basically before refractive surgery. Some of these pictures will explain that basically. We have here the picture which gives us the sagittal picture. This is the perfectly normal picture. If we look at the front elevation, this is again normal. And if you look at the back elevation, here is the steepening basically. And if you look at the thickness map, again there is eccentric, and there is, although the thickness is normal, but it is eccentric. So this basically is a keratoconus, and this can be easily missed on the placido-based system. Another one, basically, we have again a sagittal image where it is perfectly normal. Then we have the anterior elevation or front elevation which is normal. Again the back elevation which is normal. But you look at the thickness map, basically the thinnest point is quite eccentric and the thickness is less. So again this is not a good candidate for the refractive surgery. LASIK basically is going to do the ectasia. Coming to this is the advantage of this system basically, and then we have some of the images where we can have pseudo steepening like this one. All of the parameters are normal, so this is basically misalignment. Again, this one is spurious steepening, but again all the parameters are normal, and this was basically a normal picture. Pentacam has other advantages. You can always diagnose like cataract if we are considering like refractive surgery and we are not getting good vision. We can also look at the lens. Also, we can grade the nucleus. We can have AC depth, AC angle, and the AC volume also. And some of the recent like softwares with the higher models, we can even calculate accurately the IOL power in post LASIK patients, and it can also aid us evaluating how much energy is required in phacoemulsification. Again, genomic analysis of the cornea is possible. I would just like to end by saying that look at this picture. This is basically a beautiful picture taken, and all these camels which you are seeing as camels, they are not camels. Basically, they are all shadows. Camels are these. So this is what happens. This is an aerial photograph, and if you don't take into consideration the elevation, this is what happens. We will call shadows as animals. So that is what happens in refractive surgery. Also, once we are not using the system which gives us the elevation. Thank you very much for being patient here.
Thank you, Dr. Sharma, for simplifying these complex aspects of anterior segment examination. Now I call upon Dr. Manisha, and he's going to deal with gonioscopy examination. Dr. Manisha, please.
Good morning, and thank you, Dr. Preetham, for giving this opportunity. Basically, since this course talks mainly on the use of slit lamp, I will be talking a little less on gonioscopy, other things. Basically, we do gonioscopy to visualize the anterior segment angle, which we are not able to see directly with a slit lamp. We require an added lens to be used because the angle is not visible because of total internal reflection. And the main use, because first step is to differentiate between open angle and narrow angle, and there are other differences because of the diseases being different. So you need to know whether it's open angle or closed angle, and you have to determine the site of active impedance, mechanism responsible for the glaucoma, and it has to be repeated periodically during the course of the disease, that is during the lifetime of the patient. So when are you going to do a gonioscopy as a procedure when you examine the patient? First is when you see a patient with a suspiciously shallow angle. You can do the Van Herrick test, then basically in hyperopes you can put the beam on the side and see if the peripheral angle and the thickness of the cornea on an optical section which Dr. Nayak showed us, and see if it is less than 1/4, and that means the Van Herrick is positive. Glaucoma suspects based on disc and IOP, iris abnormalities which you see, pigment dispersion, pseudo-exfoliation, suspected retained foreign bodies when you have injuries, and especially penetrating injuries, and patient complaints of pain suggestive of intermittent angle closure, and ophthalmic examination for headache, which we all do a lot. We should do gonioscopy with that. And then when you see, as I said, you just examine on a routine slit lamp, you see these kind of iris abnormalities, and it's time to put in a gonioscope, and you might see the reason why it is there. Post-operatively, after you have done a routine cataract surgery, if you find elevated pressure, unexplained uveitis or recurrent uveitis, you may be wondering why the patient is getting uveitis after a very uneventful phacoemulsification. Now you see a peaked pupil which you don't expect it to, or after you have put an anterior chamber lens. Even prior to certain procedures, especially phakic IOLs, endothelial transplantations, you need to see if the angle, these are not glaucoma situations, but still you need to do a gonioscopy. Gonioscopy is basically done in two ways depending on the type of lenses you use. The one is the one which we need coupling agents. The Goldman's lens is the most popular lens in this category. And the second one is which we do not need to put coupling agents. The Zeiss, the Fosner, the Sussman, these are all the lenses which fall in this category. And basically this is the technique by which we can do indentation gonioscopy, which I plan to show you. So this is a Sussman 4 mirror, this is a Fosner 4 mirror, this is a Zeiss 4 mirror, and these are very easily available now in our country, and you can easily use them. Requirements for doing gonioscopic examination: basically you need a good slit lamp, and you need topical anesthetic and coupling agent if you are using one of the lenses which requires a coupling agent. You have the goniosol which is available. Basically you require a viscous fluid which you need to put on the lens when you want to do the gonioscopy. You have to place the patient onto the slit lamp comfortably, yourself also being comfortable. Before you do gonioscopy or even plan to do gonioscopy, you have to make sure that your room can be darkened. Nowadays, many times I have seen in places the room is not dark enough, then you are not going to be able to do gonioscopy very accurately and detect narrow angles. You will miss quite a few narrow angles if your room is not dark enough. So room darkening is very important. And then you have to make the patient sit very comfortably and try to tell the patient what you are going to do, because if you just take a lens and jab it into somebody's eye, he is going to feel it very uncomfortable. So you have to tell the patient that I am going to do a small test in which I am going to put a contact lens in your eye. If you say contact lens, because everybody has heard of it, their anxiety levels don't go up so much. So what you need to do is ask the patient to look straight, then you need to lift the upper eyelid, and then ask the patient to look upwards, and you tilt the lens first before inserting. You let the lens be tilted like that so that the inferior edge touches first, and then put the lens straight up like that. If you try to just push it in straight, you are not going to get cooperation from the patient. Even when you want to put a lens which does not have a coupling agent, these are easier to put in the eye because their basic aperture here, the touching part is smaller than the corneal diameter. So you can very easily put it. Most of the time you don't need to hold the upper lid, but you can if you want to, or you can ask your assistant to do it also. But I would recommend that it should not be held as far as possible. Then this is the first view you get when the lens is in place. This is just to make sure that your lens is properly abutting onto the cornea. After that, what you need to know is the gonioscopic anatomy. As far as the slit lamp settings are concerned, you should have a darkened room. The slit beam has to be at an angle, roughly about 45 degrees angle, and you have to put a parallelepiped kind of thing for 2 millimeters beam, but the height has to be less. You should make sure that when the beam is put onto the gonioscopic lens, it does not impinge on the pupil. When you start looking at the angle, I'm going to show you slides again. Most important is that you start from the corneal end and go backwards rather than go the other way. Because from the other way, how much you are going to see is going to be variable depending on narrow angle, open angle, or very widely open angle. Cornea is always visible. So start from what is always there and go backwards to the level you can see, starting with cornea, Schwalbe base line, the anterior non-pigmented trabecular meshwork, the filtering posterior pigmented trabecular meshwork, the scleral spur, ciliary body band, and then the iris root. So this is the way you need to start seeing from here and start going backwards like this. This is not the ideal beam, but just for photography purpose, I have made it very wide so that you can see the same thing which are pointed out over here. This is the cornea, and then you have to go backwards from here. So you will then see the Schwalbe base line, and then you will see the non-pigmented, then the pigmented trabecular meshwork, scleral spur, and this is the ciliary body and the iris root. That is another photograph of the same thing, all pointed out for you. So you should familiarize yourself with this picture. The best thing to do is to pick up patients who have already been operated for cataracts. Usually they have deep anterior chambers, and you will be able to study these very well. So people who are starting into ophthalmic practice and take first 25 patients of cataract operated and put in a gonioscope, you will be able to study this quite well in those patients. The next thing you want to know after you have seen the angle structure is whether the angle is occludable, and second is, are there any abnormalities in the angle. So when you want to look for occludability, your testing conditions have to be very strict. Patient has to be looking straight ahead. Try to make the patient fix with the eye which you are not examining. Room lights has to be dimmed to the maximum extent. Dark is the best. Decrease the illumination height of the slit beam and make it wide. Width should be around 2 millimeters. And then you have to look in the angle, making sure that your beam is not impinging on the pupil. As you can see in this picture, this beam is slightly impinging on the pupil. If it's short somewhere here, that will be superior. This is what is called a parallelepiped appearance, where you will see this is the cornea. You will see two reflections in the corneal part. One is from the epithelial side and one is from the endothelial side. When you reach the Schwalbe base line, the cornea does not remain transparent anymore at that level, and therefore this beam fuses with the inner beam, and this is the collapsing of the parallelepiped, and that is the position you will see the Schwalbe base line. Then you can trace backwards and you will see non-pigmented trabecular meshwork, pigmented trabecular meshwork, Schwalbe base line, and ciliary body. So this is the way to identify the Schwalbe base line. And then you have to give a little thought onto the peripheral iris, whether it is bulging forward, whether it is straight or whether it is concave. So this is for doing the grading of the angles, which I am not going to go so much into detail. When you want to look at abnormalities in the angle, you want to artificially open the angle to the maximum level you can. So what you do is keep like patient keeps looking straight, but increase the room light, increase the beam also. So the pupil will constrict a little bit, and you will get more opening of the angle, and you will be able to visualize things much better. After you have done this, you want to do an indentation examination. Indentation can only be done with lenses which have got the corneal, the curvature, posterior curvature of that lens has to be flatter than the curvature of the cornea. Then only it can do indentation. It is difficult to hold this lens in position because of the curvature being less. It does not stick onto the cornea like the Goldman lens. So you have to make a little effort to keep it in position. So it has to be kept in the central cornea without any artificial pressure on it. And this is what you do when you want to do indentation. You push the lens backwards and artificially this angle will open. And as I pointed out, the total diameter of this lens has to be less than the diameter of the cornea. Well, in the Goldman lens, the diameter of the lens is larger than the diameter of the cornea. So this is what you see. Again, in this I have made the beam a little wider than we usually do because I wanted to let people see it. Now I have to get this video to run. So you can see that when you put the pressure, keep looking here, and you will see that when you put pressure there, you can see the iris moved completely away, an angle which was totally closed completely opened. For those who want to see it again, there when you put pressure, the iris moved back, and this angle you can see completely becomes visible. So you know that there are no synechia there. So that is the purpose of the indentation. This is the patient is looking exactly straight. The lens does not move at all. You just move it backwards and you see the full angle opening. Here you can't see any angle. The picture is ending at the Schwalbe's line. Once you give, you can see the anterior non-pigmented as well as the posterior pigmented trabecular brushwork, and over here you can even see the scleral spot. So completely open angle on indentation. And so in other cases, when you do the indentation, you see that the angle does not completely open, and in some places you can see this tinting, synechia kind of thing has formed. So in this way, you are going to be able to differentiate synechial angle closure from completely appositional angle closure, which you cannot do by any other technique, including the imaging techniques. Then the next step is sometimes the angle looks closed in the primary position because the iris is excessively bulging forwards, and you need to look what we call over the hill. You need to look over the iris to see if the angle is open. This can only be done by manipulating the lens. And you can see in this video that you have to make the person's eye move towards the mirror, or the mirror has to be moved towards the direction of the angle. You can see over here that once it is being tilted, the lens is being tilted, and there the full angle is become visible, as compared to the original position where only the Schwalbe's line was visible. You have to see over there, and that is the lens has come out. Then there are these kind of abnormalities which you see. Sometimes you can be mistaking this kind of appearance for synechia, but this is just the iris processes. They look much more finer. The synechia would be more tinted. So these are just lacy iris processes. I think that's the end. My time is over. So I'm just going to show you just through some examples. But otherwise, thank you very much.
Thank you, Dr. Manisha. Our next presentation is on slit lamp examination of posterior segment. Dr. Sikrim Sam is going to present.
Thank you. So, many times I sometimes envy my fellows, my postgrads, because they are learning in the era of OCD and digital fundus photography and adaptive optics and fantastic
advances in technology. But then sometimes I sit back and I thank God for that I did my fellowship during the era when there was no digital fundus photography. So we used to do FFA and then send the rolls for developing, and because of that, we really got used to doing slit lamp biomicroscopy and visualizing the fundus, which a practice which is gradually dwindling. But believe me that this type of examination of the fundus has its own charm, its own advantages. So essentially the slit lamp, the mechanical slit lamp system of a slit lamp or the observation system is not geared to look at the fundus. You have to use an additional lens to do a slit lamp examination of the fundus. And how do you do this? There are basically two types of lenses, two different types. The non-contact lenses and the contact lenses. So these come in contact with the cornea. Dr. Manish has made my job easier because he showed a video of how the gonioscopy lens is placed on the cornea with the coupling viscoelastic agent. The non-contact lenses are essentially of two types, the negative and the positive lenses. The negative are the ruby and the -55. We'll be seeing all these briefly. Then the L/D lens and the 78 and the 90D are the positive non-contact lenses. The contact lenses again are negative and positive. The Goldman 3 mirror is essentially a negative lens, which also uses the mirror system to look at the fundus. And the positive lenses are the pan-fundoscopic and the mainstay lenses, which we use only for our procedures. So let's look at the negative lenses. The principle here is to place a negative lens in front of the eye and create an optical system which is analogous to a Galilean telescope. These lenses, because of the telescopic system, produce an upright virtual image with somewhat limited field of view. So the ruby lens is a -58.6 diopter lens. It's essentially a plano-concave lens. The -60 diopter neutralizes the +60 diopter refractive power of a normal eye. And that's how it gives a magnification of exactly about 1 when used with a hemetropic eye. The field of view of this ruby lens is approximately 30 degrees. When we look at the other one, the Goldman 3 mirror lens, it's a 64 diopter lens. Again, it produces a magnification of about 1. The magnification doesn't change with this lens with the patient's refractive error much. That is the advantage. Now, the other plus points of the Goldman 3 mirror lens is the measurement of objects in the fundus is possible with the Hartstein and a Goldman lens. It provides sharpest and the most accurate view of the macula and gives excellent view of angle structures. And if you practically look at it, you have a lens which is subserving your glaucoma practice also, as well as a fundus practice. So it's a multi-utility lens. The downside is that it has a limited field of view, particularly in patients whose pupil dilates slowly or don't dilate so well. Now the Goldman 3 mirror lens, you have a system of 3 mirrors. Now the smallest mirror is used for viewing the angle, which Dr. Manish so very well showed with his fantastic videos. It has an angulation of 59 degrees. Then the medium-sized mirror is used to view the retinal periphery anterior to the equator. So to look at structures like lattices, retinal breaks, or retinal dialysis. It has an angulation of 67 degrees. And the lens which has an angulation of 73 degrees is the one which is the largest mirror in the entire system and is used to view area within equatorial and post-equatorial regions of the fundus. Then we come to the non-contact positive lenses. So the most popular ones are the 90D lens and the 78D lens. The 90D lens produces a magnification of about 0.67 and has a field of view of about 70 degrees. The 78D lens produces a magnification of about 0.77 diopters, but offers a somewhat, no, that is not right. It offers a somewhat limited field of view as compared to the 90D lens. The 78D lens has a larger diameter than the 90D lens. The magnifications produced by these lenses are too small for them to be useful by themselves. So they are used with a slit lamp, because a slit lamp is the one which actually magnifies the view which these lenses give. The slit lamp magnifies that view by almost 10 times. So this is how the principle of these plus lenses. So it's essentially, this is a 78 diopter lens and it will give you a real inverted image like this. So you're seeing an inverted image with these lenses. The L/D lens also was a very useful tool. It was a +60 diopter lens that produced again an inverted real image of the patient's fundus, about 17 millimeters to the observer's side of the lens. The main disadvantage that it was so close to the observer that the slit lamp couldn't be moved so back. The slit lamp really had to be moved back while using the L/D lens. Maybe that's why it lost its popularity really. Now, if you look at the contact lenses, there's the pan-fundoscopic lenses. These lenses are mainly a system of lenses within aperture, and it consists of a meniscus lens coupled with a spherical lens. It gives a good wide-angle view of the fundus in an emmetropic eye, extending right from the fovea to the equatorial region, and facilitates examination of pupil, even examination of the fundus even through not so great dilated pupils. These are the lenses which are preferred during laser photocoagulation. Pan-fundoscopic, because it gives a wide field of view, it is preferred for even pan-retinal photocoagulation up to the mid-periphery and the periphery. The mainstar lens is the other lens which provides somewhat reduced field of view, about 45 degrees. So some of these lenses are also called as the centralis lenses. These are used again for diagnostic purposes, especially when you want to study some macular pathology, like say diabetic retinopathy or a CSR. And these are used when you are doing macular photocoagulation, precise photocoagulation, like if you are treating a focal leaks of a CSR, or you are doing a focal or a grid laser photocoagulation. There are also the mainstar wide field and the mainstar ultra wide fields which are used for PRP because of their larger field of view. So these are essentially all the lenses which we have in our armamentarium. I just want to make a small mention. Dr. Kashyap is going to deal with photography after my talk. But in fact, there was there is now this new thing about smartphone photography. In fact, there was an entire instruction course yesterday on smartphone photography. I don't know how much of you all got that. But there are now adapters which are coming with smartphones, and these adapters can be coupled to the slit lamp, and fantastic fundus pictures can be taken even with these smartphones and their adapters. So these are some of the gadgets which are going to soon come into the market and in vogue. Thank you so much for your patient hearing.
Now I would like to invite Dr. Kashyap to talk a little about the general principles and techniques of slit lamp photography.
Yeah, the documentation is very important for the counseling of the patient, for keeping the documents of the patients, and counseling purposes and for medical purposes. Now, after the advent of the smartphones, it is very easy to take the photograph of the eye. I'm about to call a ventilator segment in both posterior segment. It's very easy. You need adapters for these photographs. It could be internal attachments or the external adapters. The external adapters could be by means of iPhones, smartphones, or iPad. For the external attachment, the camera with at least 5 megapixels is required. It should be able to steady the camera. If you try taking the picture through your hand, even a small amount of shake of your hand, the photograph doesn't come well. So it has to be very steady, and it has to be good, real ideal lighting. This lighting could be external illumination or through the slit lamp. It is necessary to have one light only, but if you can use both the lights, you get a better picture. The external light could be the patient can hold the light himself, or the assistant can hold the light, or it can fix it with the slit lamp. The adapters, you can see here that these adapters are attached to one of the eyepieces, and then you have a click there. It could be you can have the adapter for the iPhone or the iPad or skylight. One of the advantages of this skylight adapter is you can adjust the telephone, or you can adjust the eyepiece also, because the adapter has to fit on the eyepiece. So you can any kind of eyepiece can be adjusted, or any kind of phone can be adjusted. These were basically, the other one is basically was for the telescope, but then it can be used on the slit lamp also. These adapters, some of the adapters are available with the objective eyepiece. The Tiger lenses are just attached on the eyepiece. They are not supplied with the eyepiece. You have a cover which get attached to the eyepiece of the slit lamp. Once the killer adapter was very, very popular. If your adapter which you have purchased is not fitting well, you can ask your manufacturer, they can supply with the correct size of eyepiece of the slit lamp so that the adapter works. And for the good quality of photos, you have to have the control of the exposure, point of focus, and zooming. Certain software are available like Camera Awesome app, which is free by Smugmug. And then what you have to do is you have to fill up the whole camera by the image, and then you can separate the focus and the exposures. And then you have to place the focus square over the specific point of interest. And as far as the exposure is concerned, you put that circle over the area of the image that is most bleached out due to the overexposure. And then you can transfer these images to your another iPhone or a computer. Dr. Fogla, yesterday he was talking about the, you can make it also. The green one is basically the shaving cream cover. The closed end, you have to cut it 18 millimeters away from that. You make a central hole and get attached to the circle. You have a circle. This circle is, you get it in the stack of the CD, where you store the CDs. In the bottom of that, you can find this circle. So you cut it, get it attached to by the rubber adhesive, and then you get attached to the slit lamp cover, and it's ready for use. It's very simple. Then you have internal devices which is attached, that is slit lamp attached camera, which is inbuilt. I think it's a better quality with necessary software to retrieve the photos and videos also, and with the name or registration, and this is where you can search. And the use of diffuser is very, very important. These are slit lamp attached photography, and then you have to click here. You can choose the mode, whether you want to have a video or you want to have a slit lamp, the still photograph. The use of diffuser is very important, and not all slit lamps they have a diffuser. If you don't have a diffuser, you can put a tissue paper, and then it works well. The upper lenses, microscopes, they have a 5-step magnification facility with detachable objective console. There is a space for the beam splitter. One side of the beam splitter can be used for the CCTV camera, and the image can be displayed on TV screen for teaching and counseling purposes. Same images and videos can be captured in the patient's EMR. What I didn't do in my practice is I keep on seeing the patient, my assistant write the prescription for me by the EMR, and the moment I see a good picture, I ask her to take the picture. So this picture is directly taken away to the EMR. So this is the slit lamp with beam splitter and a camera, and it goes to one of the TVs attached there. So whatever, if I see a good picture, good disease, something to show to somebody, I ask my assistant to click, and this thing is transferred to the EMR. The other TV is for the entire ophthalmoscope. There is a camera attached, and I can show my patients the posterior segment diseases and make them understand what is the problem. And the software used in this is Honstick TVR. There are some pictures taken by the smartphones and diffuse illumination and focal broad beams, secondary nodules, the focus illuminations, retinal illuminations. They're fantastic. And for the sclerotic scatter, which Dr. Nayak was saying, this is the knob. And this is knob for the sclerotic scatter, which allows this lamp, it has to be rocked horizontally. And you can make collage of the images. Same disease by different examinations, or same disease in progression. You can make a collage. And there are some other methods also for posterior segment, like you have to have a 35mm camera with a coaxial light adapter. This is the adapter attached to the light source, and you have these entire ophthalmoscope lenses, 20D, 30D, 40D. And you look through the camera, see the image, focus the image, and it should, like Dr. Phil is doing. This is the way it's done, and good photographs. There is retinal detachment and diabetic maculopathy, and these slides are I shared. So he shared his slides with me. I especially thanks to Dr. S.S. Patel. Thank you very much.
Thank you, Dr. Kashyap, for giving an excellent overview of these new technologies in the market. Maybe we have a couple of minutes so we can take some questions. Manish had, because he is more into glaucoma.
Well, because the 4-mirror gonioscope or the Sussman lens is what I really use, preferably. Only sometimes the Goldman lens is very nice to do photography because it gives you stabilization of the eye. So sometimes you want to photograph angle abnormalities, I would use the Goldman lens. But for routine examinations, I am using the Sussman lens.
You know what happened? Subsequently, in many cases, I thought it's a open angle. One of the colleagues said, Dr. Kashyap, what has happened to you? This is a closed, yeah. Then I suddenly realized that when you're using a 4-mirror gonioscope, you give a little pressure. Give a little pressure automatically. You think that you're just touching it, but basically giving a little pressure. And the closed angle looks open. I think it's better to go for or you have to be very, very careful.
You have to master that technique.
Yeah.
In fact, I am using the different kind of technique, which not everything I can show in this much time. But what I do is that I reconfirm the angle open or closed. The even better way is to actually see the angle closing. You narrow the slit and first you open the slit, let the pupil constrict and then let it dilate. And then by narrowing the slit or even actually switching off the light, switch it on again and immediately you get to see whether the angle, what is happening to the angle. Second is the way you hold the lens. You are right, in the beginning you will do these kind of things. But after some time you will know exactly what you are doing, how much pressure you are giving, and you will be able to judge whether this angle is open or not. But in the beginning it would be a good idea to do both then.
I found a marked difference between the 3-mirror and the 4.
Yeah, you have to do both.
Excuse me, I have one question. There is one stall down there and it is selling this slit lamp adapter. It costs around 3,000. So do you think it is worthwhile to get it or?
Dr. Zakaria, he has given his address, I'll give it to you, and he is selling it for 200 only. Yeah. It is nothing. It's something, it should get attached to your eyepiece, and then you have a frame for the posterior part of the smartphone cover, and you stick it to that. Absolutely, it's very, very easy to make it. Somebody yesterday said that instead of making a hole there, the sole, the slipper's sole, he cut it there and made a hole there so that it snugly fits in there. So there are many ways, I think, but it needs a lot of practice. It needs a lot of practice. In one go you can't do it.
So where can we find that?
I'll give you the address.
I think anything which is sold in rupees is always a good investment.
Are they there in the general body meeting? Are they there for the general body meeting? Yes, tomorrow.
So I would like to thank all my co-instructors and we conclude this session. Thank you everyone.
May I please invite Dr. Mahipal Sachdev as moderator for the afternoon session, who's actually been, we all know Dr. Mahipal is a renowned ophthalmic surgeon. He's a Padma Shri awardee and chairman and medical director for the Center for Site Group of Hospitals. Please, Dr. Mahipal. And Dr. Mahipal would introduce the panelists and chairpersons for the session.
Thank you very much, Ajay. It's indeed a pleasure to be here in this session. Well, this session particularly is a launch session of the Envista Toric, which is Envista, as you all know, is a new glistening-free lens that has been introduced in India about more than a year ago. And now they are launching the Toric and also the advancements in the Stellaris PC that would be discussed. I have with me a galaxy of speakers and chairpersons and moderators and the panelists. So my privilege to first of all welcome on the dais Professor Dr. T.P. Lahane. He is Professor Head of JJ, and also the dean. Actually, head I think is Ragini now, so he's the dean of JJ. He's a Padma Shri awardee and a very fantastic man. Has done a lot of rural work. Maybe has done more than 1 lakh or 1.5 lakhs of cataract surgery. And has a philanthropic bent of mind, makes excellent presentations. So Dr. Lahane would be the chairman for today's session. We have with us a panel. The first on the panel is Dr. Asim Sil. He heads the Vivekananda Hospital. Is he there?
Yeah.
Yeah. Could you please come and in West Bengal and does a lot of excellent cataract surgery work. May I now request Nitin Dedia, a fantastic person from Mumbai. He was the first mover in refractive surgery in Mumbai area and does a lot of cataract surgeries, a high volume cataract surgeon. May I now request Mohan Rajan? I think he's busy fighting his elections. Well, Mohan is one of the first people or one of the few people who swears by the Stellaris or the Venturi system. He's a trained vitreoretinal surgeon but is doing wonderfully well as regards cataract surgery also. So as and when he comes, we'll be happy to have him over. And finally, Kamal Kapoor. Well, Kamal would also possibly be joining. Kamal Kapoor again is one of the KOLs for Bausch & Lomb, has been using the Venturi system for long and is part of the Sharpsight group of eye hospitals. So without much ado, I will now go on to the, this session has actually 3 talks, 2 on the Invista and 1 on the Stellaris. So the first talk is going to be given by Amar Agarwal. Amar, as you all know, is somebody who has made India proud of ophthalmology that India does, because he is one of the most renowned speakers in any conferences, and the speed at which he thinks actually baffles me, and he can come out with ideas, and the time between getting an idea and implementing it is like, if he thinks of an idea today, it should have been implemented yesterday. So Amar, please come. He'll be talking about the toric Invista and we'd like to hear on the new lens which is being introduced, the toric Invista. Thank you.
Thank you very much, Maipal. At the outset, I'd like to thank Sanjay, especially Ajay, Satish, Biswas, the whole entire team of Bausch & Lomb for inviting me here for this lovely introductory session on the Invista toric. Just for your information, the registry of this lens is just going to come through, and I think what they have told me is going to happen in a couple of weeks' time and should be available. And in the July Indian Intraocular Implant and Refractive Surgery Conference on July 5th and 6th, a live surgery of the Invista toric will also be done. So basically, when we are looking at various aspects here, we are looking at the material and the design improvements which have helped to make the Invista, and especially now the Invista toric, one of the leading brands for Bausch & Lomb. And as you can see, basically, this sphere power ranges from +6 to +30 diopters in 0.5 diopter increments. And one of the problems which we always face when you are handling toric IOLs is, do the companies have backup of the cylindrical powers? That's one big factor. And you can see here, they've got a good cylindrical power base there, and which is going to be extremely helpful. Another factor which, we don't have a pointer here, another factor which is important is what is the material it's made of. Because people would obviously be scared of using materials like silicone, and you can see it's a hydrophobic acrylic material. Now, this is now obviously a single piece lens, hydrophobic acrylic lens, which helps make things much easier for us. And with this 360 degrees posterior square edge, you will see obviously things becoming very good. Now these are the various material benefits of the Envista toric, and because they are better lenses, made much better, I think quality of the lens, once it is achieved, you will obviously get a better visual quality. The surface roughness is an extremely important factor, and you can see here when you compare the Envista compared to the other hydrophobic intraocular lenses in the market. Now when you compare also the IOL hydrophobicity, you will see how the Envista compares to other lenses. So these are various factors of the Envista lenses, and after 15 days of hydration in physiological solution, again you are comparing the Envista to the other hydrophobic IOLs, and you can see once again all these data have been filed there, and you can see there in the lowest column there where it was being published. The nano indentation study of surface hardness is also being worked out here, and this was presented in the ESCRS conference here. You can see once again here, because of the Envista having high surface hardness, there are fewer scratches during surgical manipulation. One of the things sometimes is when we do manipulate these lenses, we tend to damage them, and if the surface hardness comes into a factor, it will help us a lot. I discuss about the PCO features, which obviously you all know about, and obviously because of this design of these lenses, and you can see the step vaulted design, the PCO opacification becomes much better off here. And you can see the Envista PCO trial results, where the results were scored, and you can see the areas and the journals where all this material has been published. Now if you compare the Acrisoft, this is one of the biggest problems with the Acrisoft, and you will see the posterior capsule opacification there occurring, which is a big advantage with the BNL lens. One of the other problems with companies or competing brands are the glistening factors, which happens, and perhaps in the Envista that one factor does not happen at all. So it makes things much easier and much better. Now another problem is you don't want a lens going into the eye and then rotating post-operatively, because a little bit of rotation also can create a problem. If you see the design of the lens, it has been designed in such a way there is a maximum contact angle between the haptics and the capsular bag, and this makes a huge difference in the stability of the lens. So another big key factor which the designers have designed is these fenestration holes, as you can see. So they limit the transfer of the capsular contraction forces into the optic. The anterior offset of the haptic, and this is a side view, helps also in making these lenses much better. Now the question comes, how did these perform? And you can see here these results being at least 91 to 92%, even 4 to 6 months down the road, 92% is an excellent idea to show you the Envista toric. And you can see here 1 day, 1 week, 1 month, and again you will notice the Envista toric axis remaining nearly the same. It has also got an AO technology, and you know these Bosch people always have used this AO technology in the previous lenses also, which gives an aberration-free aspheric optics. This helps a lot, helping any post-operative spherical aberration, image degradation, etc. And if you see the enhanced depth of field of view, you will compare the spherical aberration and with the simple spherical here compared to the one on the top. The IOA is a basically decentered optical system, and the visual axis, as you all know, does not pass through the center of the cornea, and there is a little bit of decentration between the axis and the pupil, and between the IOL and the pupil. There is effects of IOL decentration, so one has to be extremely careful about this. What about the BCVA in about a 6 months visit? You'll notice again it has improved extremely well. The Envista toric under the European Union registry data was shown, and you can see here 48 eyes were done with 1 to 2 month follow-up, and you will see here the basic data which is coming out in these data here. And again you will notice 97.9% in this. In this, what you realize is the mean cylinder reduction was about 85.3% and the mean IOL rotation was only 3.6 degrees. Now let's look at some practical considerations of this whole thing. They have a very good cylinder calculation, and obviously a lot depends on the corneal astigmatism, and you can see this is how the formula is made, and the BNL people will obviously help you. So once you get this in your hands, you will be able to treat any patient with this astigmatism of 1 or anything more than 1 diopter also. Now let's see the surgical procedure. Basically, it's like the normal toric lenses where you're marking the steep meridian. You can make your incision depending on whichever one you want, and after doing your phacoemulsification, implant the IOL and align it properly. So when we take the toric IOL summary, you can see a lot of plus in the Envista toric compared to the opposite competitor brands. And now, as I told you, it's available now in India soon. And I have to thank all of you guys from the Bosch and Lomb, the leaders who have helped all of us doctors come under one platform, to not only talk on the Envista toric, but perhaps to teach all ophthalmologists the way to implant these lenses. Because the older techniques where we are using the LRIs, etc., have obviously given place to these toric IOLs. And today, I think globally, if you see, more than 50 to 60% surgeons are implanting now toric lenses, which make a huge difference. A point which we all have to understand is these premium lenses are a huge market. The faster the surgeon understands it, the faster and the better it's going to be for him. Thank you very much.
Thank you, Amar. I think the Amar has really put forth everything about the toric. And the toric we are using from other companies also. And I am also using the toric from, I think they are about 2 years. What is here, what Amar says is the haptic, that angulation 62 degree, and the contact of the haptic to the peripheral capsular margin. See what happens if that periphery, that means the haptic is not more in contact, so the fibrosis will not happen early and you will get the rotation. If the rotation is up to 10, I think that may be the problem, because there may be 33% of the vision disturbances you can see. So it should be less than 10. And for that, I think the whatever angulation in this lens will definitely help, and secondly the contact of the capsule, that will be much useful. So I think who is the second speaker? So Murthy is going to speak on Envista. Okay, Dr. Murthy. Second, as he is opening, I am using this Envista from near about 2 years now, and I compare with others. The factor of glistening is not there at all in this lens. I have implanted the Alcon lens in one eye and Envista in other eye, and the people are happy with that. And sometimes if that glistening is in the center of the lens, Alcon IQ, that is very much troublesome, and if it is in the VIP, then we will have to cut that lens. So which is not there in the Envista lens. So Dr. Murthy.
Thank you, sir. Respected chairpersons, my teachers and colleagues, and I really thank the portion of people for making such a wonderful lens, which I am constantly using from past 6 months. And the aspect of glistening, in fact, most of us are not aware of it. And even myself, it took for me, my own actually relatives whom I operated 10 years back, when they started coming to me with a decrease in the night visual acuity and a central glare started happening. That's when I started looking at glistening, because most of us who have been used to few forms of hydrophobic IOLs were never exposed to a factor called glistening. It's just from the past 1 year that, yes, really, I started to look glistenings on the IOL of the patients. because most of us actually feel that PCO is the only cause for the degradation of the vision over a period of time in an hydrophobic IOL, whether it's 3 or 5 years. But we never looked at glistening. Okay, the patient has improved after the YAC cap, that's it, we stopped at that point. We never went across to see whether glistenings really happened or not. Now, that's when we started thinking upon glistening, and the Envista with the new glistening-free IOL has come into the picture. And the glistenings are nothing but fluid-filled microvacuoles that may form within the optic when the IOL is in an aqueous environment. And they are observed in all types of hydrophobic IOLs which have existed till now, but they are primarily more so with a natural hydrophobic material or the colored hydrophobic material which we constantly use. There are lots of causes of glistening. Few of them are the non-uniformity of the lens material produced by the molding technology, and the changes in basically it's the changes in the equilibrium content of the water which is caused by the temperature fluctuations. I still remember in 2001 or 2002 we used to warm the lens to a very significant degree, and then actually we started implanting the lenses, and most of these lenses ended up with glistening. The post-implantation causes are again the temperature changes which can happen in the anterior chamber and the water vacuoles which form, and typically few of the patients like glaucomatous or diabetic patients whom we operate in a very large numbers, and they are the ones who are very prone for these glistenings. And any patient actually where there is a breakdown of the blood aqueous barrier, there is always a chance of glistening formation. Now, how these glistenings were eliminated is at physiological saline levels, the osmotic difference between the IOL and the aqueous humor caused the water absorption into the IOL aptic. So we wanted to prevent that, so this created a differential refractive index resulting in glistenings. So basically the concentration of the hydrating saline solution was reduced from 10% to 0.9%. So the equilibrated lens and the low concentration saline solution led to the first hydrophobic acrylic glistening-free single-piece lens, now known as Envista IOL. Now, as Professor Amar Agarwal has already illustrated very nicely about the qualities of the Envista material itself, I will not go into much of details. Now, what I would like to concentrate is on the glistening rates, which is really 60% between 4 to 22 months. And all of us, we agree upon that most of our patients are lost to follow-up, or they're not under constant follow-up over a period of 3 years to 7 years, and this is the time when the glistening starts happening and the visual acuity starts going down. Now, the Snellen acuity in glistenings more than, which was 2 plus and which was in the visual axis, was almost 1/2 line lower, and with more and more of contrast sensitivity studies coming across and the quality of vision being a basic parameter in the outcome of any patient after cataract surgery, definitely glistenings, even if they are minor or even if they are grade 2 to 3 plus in the visual axis, will have a major role and major impact on the visual acuity of patient. If you see this is one of the grade 3 plus glistenings actually, though we don't see much of these. There are more than 50 to 100 cases reported from each of the studies actually in a series of more than 3,000 to 4,000 patients. So with an average approximated incidence of around 1 to 3%. Now if you see the glistening formation in hydrophobic acrylic material, it's because of the non-homogeneous polymerization of the optic material, as I told you earlier, and the light is refracted and scattered at the water polymer interfaces, leading to the sparkling appearance which you see in the slit lamp. And that's what causes the scattering of the light, leading to decrease in the contrast sensitivity. Now, as I told you earlier, there are certain factors which influence the glistening. Few of them are the patients who have a problem in the blood aqueous barrier, and there is a statistically significant association between the incidence and the severity of glistenings in glaucomatous patients. Since we concentrate more on other issues in these patients, actually we tend to overlook the glistening part. And diabetes is almost 50% of the patients were having glistenings over a period of 3 to 7 years. And the FDA has now, I just come to the point that just finished a study actually which quotes almost 50 to 70% of glistenings in diabetics. If you see the long-term favorite, the old lens, the PMMA material which was used earlier, was quite rigid and was very, very resistant to abrasions, and the optical quality was quite good. And that's what actually, even in the folded form, the Invista has got, that material has got the same qualities which prevent it from having glistnings. If you see this, the IQ patient, if you see these are the, what we don't actually concentrate, even myself 3 years back or 2 years back, I didn't focus on these patients actually whom I thought that yes, this may be the capsular glistnings or the post-capsule surface actually which we have left without doing the polishing. But these were actually in the lens actually, which really mattered to us over a period of time, and if it happens in a multifocal lens, definitely it's going to affect the quality of vision because the scattering of the light is already there in these multifocals. So the conclusions which were drawn by the health organizations across the world is the glisnings which were seen in the acrylic IOLs, they're not present on the day one which we missed, but they appear to be acquired, increasing over a period of time from 3 to 7 years. So 1+ to 2+ glisnings, they usually do not significantly affect the vision, though contrast sensitivity was not measured much in these studies. But definitely there is a difference in the glare disability and contrast sensitivity and also the quality of vision. If you see the incidence of glistening, it varies from IOLs, it has come a long way from 1993 to almost till 2013. There are studies of glistenings, but surprisingly nothing has been highlighted till now actually, no conference. Even this, as Professor rightly pointed out, there's no chapter on glistenings or anything like that. Now, one point which we need to note is that most of these glistenings, they happen in almost all the hydrophobic lenses, and they quite increase over a period of time. They keep increasing with the fluctuation in the blood sugar, with the fluctuation in the aqueous barrier, or any problem actually, any small inflammation happens over a period of time. Yes, there is a definite glistening which is happening. If you see the light scatter effect, the comparison of acrylic materials, the typical that what we get, the forward scattering effect, we call it the cat's eye reflex, which we have in typical patients of AcrySoft, and most of the people are identified by that. And so functional significance may be underestimated in the clinical situations, which may be very, very obvious in the actual situations with the patient work. So if you want to tell the patient that what exactly the glistening can cause or what harm does it cause, you can quote that the lenses with glistenings can scatter greater than that present in a 70-year-old crystalline lens. So if the cataractous lens which has developed at a 70-year or a 75-year-old person, the scattering which is caused by that lens, actually the same scattering will be caused by the glistening over a period of time. So since the longevity has increased with the patients and more patients coming for long-term follow-ups, more than 3 to 7 years, so glistening should be a part of our mental makeup that yes, this is what we need to see in the patient. So this is one of the Canadian Health Organizational trials actually which they have done. They say that the stray light log, if it goes beyond 1.47 actually, then if you see the grade of against the light phase recognition and other things, if you see this is the patient with even with 2+ glistenings or a mild glistening actually with a stray light log of more than 1.47. So definitely the quality of light and the quality of the vision which they are going to see in their working conditions is going to get affected over a period of time. So this is how it affects the driving at night. You can see there's a lot of scattering which happens. If you see that there are a lot of adverse reports due to glistenings, and FDA has been consistently updating itself, and there are more than now almost 110 records can be found till 2013, and most of them were the routine lenses which we used earlier, the AcrySoft lenses, and the decreased visual acuity or symptoms actually leading to decreased quality of vision. Almost there were 14 to 15 reports in the literature actually which say there was explantation of even these lenses because of the glistening effect. So if you see the reviews, they say that initially we implanted most of the natural lenses. Actually, they don't demonstrate any clinical benefit in comparison with the currently available IOLs. This was the FDA total report which was given to the subjects. And in their review, they found that the blue filtering optic doesn't have any role. In fact, it decreases the contrast sensitivity and the best possible visual acuity, which we all need to remember. Finally, the commentators stated that the glistenings associated with the AIOC lenses of the same material, natural material, which was claimed, causes disability glare rather than actually reducing the glare which is there. And in fact, when I started asking with my own patients, definitely, since they are my own in-laws and whom I am operated, definitely they started comparing actually, and they found that yes, this is what it is. So if you see, there is an International Society for Intraocular Lens Safety. It clearly states the status of glistenings actually, and the report which has been given has clearly stated that there is a decrease in the visual acuity over a period of time, along with the decrease in the glare as well as the contrast sensitivity. So this is what the Department of Health and Human Services concluded US. Now, till 2013, there's a recent one. The Health Canada received around 69 reports of glistening suspected of being associated with the IOLs, and definitely in around 90% of these cases, the quality of vision was affected. The only point which I need to drive across is glistenings do exist. They decrease the visual acuity, and we need to keep that in mind. There are few studies which have been done on the glistenings in AIOC intraocular lenses. Few have found that yes, they need to be in very substantial number to decrease the visual acuity. But if you see the pitfall of that is those studies that they're not evaluated properly, the contrast sensitivity or the glare disability. If you see the clinicaltrials.gov, which actually concludes and gives us the recommendations for all the Cochrane trials and other things, that it says that yes, till it just concluded and they found out that yes, significant glistenings do exist and we need to look upon that. And as Professor Amar Agarwal has rightly pointed out, that it is a quite good aspheric aberration-free optic actually, which even has a little movement in the rexus, or even if it's a little bit on either side. I fully agree with him that the human eye is not completely free of aberrations. So these are the lenses which have us from center to the periphery with the same power. Really, even if it decenters or even if it moves a little bit, even if your axis is not on the completely round or circular, really it tolerates well when compared to other lenses. The most important advantage personally which I have found is that there is slow controlled unfolding. I think other seniors might experience the same. There is a very slow controlled unfolding which helps me to remove the viscoelastic, which is the main cause for TARS in most of these patients actually. So there is not a single case of even a smallest reaction actually which happens once you remove completely the viscoelastic, and the really unfolds like a butterfly, and 1.5 minutes it takes for the lens to go and touch the back. By that time most of the visco is out. You need not go behind the lens to take it out. And it's a non-wettable, really hard surface. I fully agree with the Professor Agarwal that it's absolutely scratch resistant. Yesterday I was discussing that I had almost many patients where there was scratches, minor scratches in the other lens, which is quite pliable and it tends to come out of the back. I feel the toric Envista should be a real trendsetter for the toricity, and it should be maintaining itself very well centered in the back. And I feel like it's very stable in the back and very good centration which we have found. And till now I implanted around more than 500, but 300 of them have completed the around 3 months follow-up, and 22 had the other eye being AIOC and this eye being Envista. They feel comfortable, but I feel that another 6 to 8 months or 1 year is required for the validation of these statements. And so, as Dr. Apple pointed out, one is justified in asking the question that why implant a lens which has a potential for glistening if there is a need of equivalent quality IOL, indeed that carries out all the functions of the lens, but not in comfort with glistenings. And the choice is for us actually to decide that yes, we need to put the lens. 1 or 2 points about the handling of the lens as